But first, a little bit about the anatomy. The anatomy of the groin region is in itself a little bit complex, and one of the reasons for that is that a lot of these structures are inserting. They are situated here centrally, and they can be a little bit difficult to distinguish from each other. So you need to know your anatomy. You need to know your way around. We got the adductor group. We got the hip flexors. We got the inguinal region with the abdominal muscles, and so on. So it's quite complex. There's some nerves there that you need to know about, and that sometimes can be trapped. Sometimes, especially when you have inguinal-related problems, can be a problem. Especially the genital branch of the genitofemoral nerve, and this is one of the nerves that can give rise to problems in this region. Another one is the ilioinguinal nerve that also sometimes can be a problem. There's lots of muscles. There's the whole adductor group, the hip flexors with iliopsoas and rectus femoris as the two most important. There's the abdominal muscles, both the rectus femoris and the oblique muscles. The glutes, the rotators and the hamstrings are not obvious groin muscles, but they are pelvis related, and the pelvis is the key to all of these problems. So I think we need to know them. We need to know our way about testing them and where they are. In recent years, there's been a concept of the so-called pubic plate. And I think we need to discuss that a little bit further. There's been some new additions to the literature recently that are sort of telling us a little bit more about what it's all about, but I'll just take you through my thoughts about this. This is an illustration from a paper showing that the external oblique is going directly into the adductor longus. Somehow they are crossing each other. One muscle is upon the other. I don't understand that. And muscles, these two muscles are sort of going from one to the other. And I think it's beautiful dissections like this that confuses people who are not working, at least surgically or anatomically in depth with what is actually happening. Because what you see here is superficial tissue that is connected to each other. But it's thin superficial tissue that is only situated above the muscle. So I would sort of say this concept of the pubic plate, that all the muscles are inserting into a fibrous common aponeurosis sitting here in the front of the pubic symphysis, is wrong. Let me show you. This is another paper claiming that the rectus abdominis is going down here. This is the pubic bone. So going down in front of the pubic bone and directly coming, the adductor longus is coming up here. So they are inserting into each other, and the rectus abdominis is going down here. When I saw that first in 2008, I was quite surprised because they claimed that the muscle was down, and I thought the rectus abdominis was up here. That was what I learned in school. But now they say it goes all the way down here. And they actually claim that they have lesions where the rectus abdominis is pulled off the pubic bone. I tried to look for it. I never saw it before, and I haven't seen it. I tried actually to look for it. But you should remember that muscles are inserting into bone, and they're acting from bone to bone. This is what muscles do. Then there is superficial tissues that is connected. And it's not always clear what is the reason for these. We saw it on the first day when we had on the hamstring avulsions, and Anne van der Made showed us that there is superficial connections between the sacrotuberous ligament and the conjoint tendon, and when it's pulled off, these might hold the tendon back and give it a chance to heal. And of course, this could be the case here as well, and I'm sure that this will be some of the stuff that Ernest will talk about a little bit with the surgical things. But these superficial connections are superficial. They are sort of a sheath between these muscles. Take a look at this series. If you look at this small movie here, it goes down like this. So I'll put it back here. So this is the superficial cruise that is just dissected off. And what you see here is now the adductor muscle down here, and then a thin superficial connection and these tissues are connected. And nothing is done by coincidence in the body. So there's, of course, a reason for this. So they are connected somehow, but the muscles are not connected like this. The muscles are acting from bone to bone. This is how they move the extremities. This is how they stabilize the body. So I think this has led to a misinterpretation of the anatomy. And that these all these muscles have a main insertion, common insertion, this pubic plate that sort of floats around in front of the anterior pubic symphysis. And this has led to a lot of misunderstandings of what should we actually do, how should we diagnose these patients. So I just said that before, they are acting from bone to bone. So if you look at this, for instance, we have here the pubic tubercle, where you have the conjoined tendon of the transverse abdominis and the oblique, external oblique. You have here in the front, more medially, where the rectus abdominis is inserting. And if you look at this one, you can see that this is where the rectus is inserting, and down here we have a pubic crest where the pyramidalis muscle is inserting, and down here we have where the adductor longus is inserting. I'll show you some beautiful dissection that Ernest Schilders did before in a moment. So this concept of the rectus going down in front of the pubic bone, of the muscles connected muscle to muscle instead of muscle to bone, forget about it. Instead, look at these beautiful dissections. This is from a paper by Ernest Schilders and Shirin Baram that has been accepted to Kesta. I think it is online. Yes, it is. So, and what you see here is the pyramidalis muscle up here. This is a triangular muscle. A lot of you forgot there was a pyramidalis, right? I did until Ernest started to talk about it. But there's a muscle there, and it means probably it's there, and it's there in most people actually. And what's the function of that muscle, and what's the function in the anatomy, the understanding of the anatomy? We have the adductor muscle coming up here, and we can see partly up here the rectus abdominis behind the pyramidalis. Then we take off the pyramidalis and flip it down. So now the pyramidalis is down here. And now we look at the pubic symphysis in here, and then we have the rectus abdominis situated here on top of the pubic bone. The adductors are coming up here. And here comes the money shot. The rectus sitting down here with its bony insertion. The pyramidalis was inserting here, and you have the bony insertion here, but it's taken off for visualization. And down here you have the adductor longus that would insert up here with its bony insertion. Then you can discuss, it's not just a bony insertion, here's a very special insertion. I'm sure that Ernest will tell us more about that in a while. But I think looking at these images back and forth and again, and if you have a chance, find the paper and take a look at it. And there's some very beautiful illustrations, and it opened a lot to me, and also gave me my childhood understanding of the groin back after the confusion around the pubic plate and all of these studies. So these were the lesions that they claimed existed, that the rectus abdominis was pulled off down here, but that's not possible because the rectus is going here. Well, is it then the pyramidalis that is pulled off? It probably isn't, because what happens in most cases, in most of the MRIs that they use to build this on, is that they are 1.5, 2 centimeters from the midline, and then they are actually out in where the adductor longus is inserting instead. So remember this. It's 3 separate insertions that are superficially connected, of course, and especially the pyramidalis and adductor longus has a connection that Ernest will come back to later. And here you can see the MRI images I told you about, where you have this lesion, but it's obtained lateral to the pubic midline. Then we have the hip flexors. And first of all, we have the psoas. The psoas is an incredible muscle. It's difficult to find. It's not one of these muscles you just go in there and palpate. It's not superficial in any way, but it's a huge muscle, the psoas itself, and then joining with the iliacus. And if you think of it from down here up there, so it's originating here and inserting up here. If you turn around a little bit, then it's not just a hip flexor, it's a stabilizer of the pelvis, it's a stabilizer of the trunk. And as such, it's extremely important muscle for all pelvic function. So if you have a problem with your hip joint and you have pain, you have maybe a labral lesion, FAI syndrome, you have pain there, then you need more stabilization to avoid the painful positions, and then your psoas gets in there. It's strong, it's a big brother, it always starts to work, and within a month or two, it's getting overused, it's starting to get pain, and you have secondary psoas problems. We see secondary psoas problems in many hip and groin situations. So it's very important to know this muscle, to know how to examine it, and also a little bit about how to treat it. So this is a very important muscle to know. Then we have the sartorius and also the rectus femoris. We are coming back to that in Andreas' talk. Do we see lesions there? I've never seen an overuse lesion of the sartorius. I've seen some few overuse or late acute lesions of the rectus femoris. But I think that when you see Andreas' figures, it will give you a little bit of a surprise, at least in some of this context. This is a very beautiful dissection that was done by these two gentlemen in Aspetar. That's Anne van der Made again, who is a very, very good dissectionist, if that's a word. And he worked together with Andreas in their lab and did these very nice dissections. And I love these pictures. This is the hip joint. You have the labrum here. You have the rectus femoris coming in here. And I'll just give you, oops, sorry. And what's happening here is that the direct tendon, you can see it goes back here and it inserts into the anterior iliac spine. The inferior spine, and then this is the indirect head, and it goes all the way to the acetabulum and around and goes all the way over here. So this is a strange part of the tendon. It is like this, and this one goes up where we always believe that rectus femoris is, but there's a big part of the tendon that goes all the way around there. What the big idea is about that, I'm not quite sure, but it inserts into the acetabulum there and also at the capsule. And when you have lesions of the tendon there, you can have lesions of the joint as well, labral tears with big lesions as well. So this is something you have to think about when you see these patients as well. It's rare, but it's there. And then finally, the inguinal region. I'm not going into any details about that today, but you have the oblique muscles, and they are very important, both in the conjoined tendon inserting into the pubic tubercle, where a lot of the patients with inguinal-related problems have their pain, but also as part of the posterior wall of the inguinal canal, which is one of the main problems when you have inguinal-related groin pain in athletes, the entity that some prefer to call sports hernia, which is not a good term, so we prefer inguinal-related groin pain. And then, of course, as I mentioned, the hip joint with FAI syndrome, the FAI, the CAM, the pincer, the dysplasia. You have to know the anatomy of the hip joint as well, and if you treat groin problems, you need to be able to diagnose and look at the hip problems as well. So, thank you for now from me, and then I'll give the word to Andreas.
Hello. Perfekt. Thank you very much. I'm happy to see so many people here. I apologize for my voice. It doesn't have anything to do with the party. It came before the party. But I hope you can understand me. So I have to talk about the diagnosis, imaging, and the treatment. So I really have to get through a lot of stuff in a very short time, so I'm not going to be able to cover everything that we've done and everything that we're doing. I'll cover the key points of my PhD thesis, which was on the diagnosis and imaging, and I'll briefly set up Ernest for some stuff on the avulsions. But now we just had the groin anatomy explained, but when you go around different places in the world, there are different definitions of what we consider as the groin. Some people will say that it's only around the pubic symphysis. Groin strains would be only the adductor ones that we call that. Some will consider the area around the inguinal ligament, and some will consider the whole front area here. And we're really lacking in anatomical borders. So if we just do a quick count here, who will go for A as the groin? No one. B? A couple. C? Only a couple. And D? Almost everyone. If we then look at the definition, we have the external junctional region between the lower part of the abdomen and the thigh. So the junctional region is probably more related to the C. But we still don't have these anatomical borders. And what we did in our study is that we included everything, so all the different structures that Per just went through. And we grouped those in 3 different categories. We had the hip flexors with the psoas, rec fem, and sartorius, also the TFL. We had the different abdominal muscles, and we had all our different adductor muscles. So these are kind of the 3 main groupings we did of the acute groin injuries. So if we look on the diagnosis and imaging first, we need to get an overview of what is it that we actually see. So we started out saying, okay, what is the clinical diagnosis of the patient that comes through our clinic down in Aspetar? And we did a standardized clinical examination form for the sports medicine physicians and for the radiologist as well. And what we found first was that you cannot always expect that the imaging will give you the accurate result. So you need to have some confidence in your clinical examination, because in about a quarter of these cases where people will present with acute groin pain, you will not find any imaging findings suggesting an acute injury. Then we found that 2 out of 3 injuries that we saw of the patients that came in with acute groin pain, they were related to the adductor muscles, so an acute adductor injury. And 9 out of 10 of these were adductor longus injuries. So really a main focus area in acute groin injuries. And if we saw yesterday from the good study in Norway, that if we focus on the adductor muscle and adductor strengthening, that's going to give us a real good effect on overall groin problems. We also had a number of iliopsoas injuries and rectus femoris injuries, so these are 2 next groups. And about a quarter of the cases, there was pain in the clinical examination, but when we looked at the imaging findings, a lot less frequent, and the distribution was a lot lower. So this is something that we looked a little bit more into. And when we consider acute groin pain, there's very rarely any pain in the abdominal muscles. That usually comes in connection with adductor injuries or another injury, and very rarely anything in sartorius also. So when we look at this difference between the clinical diagnosis and the imaging findings that we had, we can see that whenever the sports medicine physicians diagnosed an adductor injury, they were usually right, because there was rarely an injury in a different location. But when we looked at the iliopsoas and the rectus femoris diagnosis, often you can see that in about a third of the cases, at least a third of the cases, there was an injury in a different muscle and not in the muscle that was also diagnosed. So what we can see is that the sports medicine physicians were generally good at confirming or good at diagnosing the adductor injuries, but the hip flexor injuries were less than half of them were confirmed by the imaging, and about a third of them were actually wrong. So then we looked a little bit more into the imaging. We made a standardized scoring protocol for the radiologists. We scored a number of different parameters, whether there was an acute injury, the muscles that were involved, number of injuries. We also looked at the grading. We did a simple grading from no injury at all for each muscle, whether there was a bit of hyperintensity. We defined that grade 1 injury, grade 2, partial disruption, or grade 3, a complete avulsion or a complete muscle tear. And then we had 2 different radiologists who were not involved in any of the clinical examinations or actually not really related to any clinical stuff in Aspetar, go through the images separately, so blinded to each other's finding, and one of them did it on another occasion as well. And what we saw is that both the inter and intra-score reliability was almost perfect. So they were really good at reproducing these results. So a lot less certainty there. We also scored the more detailed measures of the edema, so the extent of the injuries in millimeters and proximal distal. We measured the cross-sectional area of the muscle and so on, and did the same process and see how good are they, how reproducible are they. And we saw the same, almost perfect reproducibility, really good at reproducing the results, and only very minor variations in their small scoring measures. So now we feel more comfortable that when we have a finding, we have a positive finding on the MRI, we can trust that the radiologist will give the same response, and that will also suggest that there is some validity to our findings. So then what we also did is that before the MRI, all the imaging, I would go through and I would do a standardized clinical examination. You can find the detailed descriptions of the different tests in some of the papers, in the appendix. But basically it was based on pain provocation test as the main thing related to the diagnosis. So we had palpation, different number of palpation. You got to go through all the structures, and as Per says, it's really important to know your anatomy so you know what is it that you're feeling and whether that when you push that structure, does that reproduce the same pain as the patient is reporting. We did a number of muscle stress tests and resistance tests. And then we compared that to the MRI findings, so the standardized research scoring of the MRIs. And what we're hoping is to get more detailed information on which test is it that are good, which test do we need to be more concerned about, so what can we actually do in our clinic, what can we recommend for tests to use, and how certain can we be in our diagnosis. So what we generally do in this thing is we have this pre-test probability, then we do a test, and then hopefully we'll have a better probability of an accurate diagnosis afterwards. So our pre-test probability is just based on the actual distribution of the injury, which we saw from our initial overview and from the study sample, is that when you have a player with an acute groin injury, when we had a player with an acute groin injury, there's about 50% chance that the MRI would be positive in that player. So without even seeing the chance, or without even seeing the player, you have about 50% chance of being right if you say there's a positive adductor injury. And then we looked at our different adductor tests, and we found that if you just do a simple adductor squeeze or an resisted adduction in outer range or an adductor stretch, we increase that the best way, and we get a post-test probability of about 80%. So when you have these test positive, individual test positive, you have about 80% chance of positive MRI. So we can't be 100% certain that we'll have a positive injury or a positive MRI, but we're pretty confident that we're improving our accuracy. On the other side, if we want to rule out that there's an injury, the best test to do that was palpation. So if your palpation of the different adductor muscles is negative, then you can be pretty confident in ruling out an MRI. There are some of the muscles which are a little bit more difficult to get into and to detailed to distinguish in a detailed manner. But in general, if you don't have any palpation pain, you're unlikely to have a positive MRI. So this number here is influenced also by the number of imaging negatives. So if we then take away the cases where there was no imaging findings at all and consider only the cases with a positive MRI, and consider that as a gold standard. So if there's a positive MRI, we believe that the MRI is showing us a right injury, that actually is the injury that the player has. So if we only analyze these cases, we went up and looked at all our adductor tests, and they were basically all above 90%, up to 97% for the individual test. If they're all positive, they all had an adductor injury. So what we can get from that is that we can have a really high confidence in that our adductor tests actually will give us an accurate diagnosis of an adductor injury. So then we looked at the hip flexors. They were a lot less frequent. We did all our different pain provocation tests. We did our palpation, we did our resistance, we did our stretch test. And we got better, so we were able to get a higher positive predictive value, a higher probability of a positive MRI. But the post-test probability only got up to around 60% at its best with the palpation, which in a clinical situation, you have to worry a little bit if you actually want to be confident in that diagnosis. So some really poor pain provocation test for the hip flexors, but I'll get back to that. But then on the other hand, if you want to rule out an injury, again, palpation comes up as the best test to rule out an injury. So if you have pain around the anterior hip region and your hip flexor areas, your palpation is negative for the individual muscles, you can start to rule out the different muscles. And we had a post-test probability of 96% of actually ruling out an injury. So you can be really confident in that. We then did the same where we took away the imaging negative cases and considered only the positive cases as our gold standard. And we can see that it actually didn't improve our results, unfortunately, for the hip flexor test. So there are different reasons for that. And the main reason is that once you have an iliopsoas injury in the acute setting, you get them in, you have to examine them. They're often painful in a lot of different locations. So they'll be painful when you press the iliopsoas, when you palpate the iliopsoas. They'll be painful sometimes when you touch the sartorius and the rectus femoris, even though there's only an injury in one of the muscles, because usually there is only one muscle injury in these cases. Then we just skip over to our anatomy again and what we see on the imaging. So we wanted to know a little bit more about the different injury characteristics of the different muscle injuries. And as Per said, we have the different structures around the pubic symphysis. And as the muscle then comes down, we have the adductor longus tendon, proximal tendon going intramuscularly here. When it comes further down, it's actually completely within the muscle. And then we have more tendon aponeurotic structure in the distal part of the adductor longus. So if we look at our injury, this is the distribution that we saw. About a quarter of the cases, there was an injury in the proximal insertion, and the rest were down in the muscle, almost evenly distributed. But what we also saw is there was a high number of distal adductor longus injuries, which is something that we haven't really been aware of before. So really interesting finding there. And one of the things that we saw is that when there was an injury at the insertion, in 75% of these cases, there was an actual adductor longus avulsion. So if you get patients in and they have pain, they have an acute injury, they have pain at the insertion, you have to be aware that there's a high possibility that they have an avulsion. So that's an important point. And then we go down, we go into, if we consider all the hamstring stuff that's come out in the recent years with a focus on the intramuscular tendon and disruption of tendon tissue may affect your prognosis. We wanted to know how frequent are these in adductor injuries, because we do have this intramuscular tendon there, and we can see that these were very rare. So there were basically all of the injuries happen at the musculotendinous junction, and we only had one injury where there was a bit of tendon disruption. So not something that you should consider as a standard part of your considerations. And then we have these two interesting differences within the adductor longus muscle, and we can see here I put two MRI images on top of each other, and we can see here the proximal tendon going down here, and we have the injury around here with the edema extending down the thigh, and we have the edema from the distal lesion proximally here, which means that if you just go in on the middle of your thigh, you're going to be pressing an area which could be similar regardless of where the injury is. And that we don't know how much that's going to matter for your prognosis, but the differentiation can potentially be made from going around and pushing a little bit more on the back side of the adductor longus muscle, and then you in my experience, you'll probably be more likely to have a distal lesion. We go over to our rectus femoris again, and we have more than just the proximal insertion. As Per explained, they also have the distal tendon, which goes posteriorly on the muscle. You have the patella here, and then the distal tendon goes up as an aponeurosis and actually extends all the way up to about 3/4 of the muscle. So it's a huge area of muscle tendinous junction, both proximally with the indirect tendon going down more than the midway through the anterior thigh, and the distal tendon going up. So a lot of different locations, and we can see the detailed structure of the different tendons within that. So we were looking only at groin pain, so we only had the proximal part of the rectus femoris, and we can see that there are different locations. But one of the things that we found with these proximal rectus femoris injuries was that there was often a tendon injury, and that would be either a tendon avulsion or a tendon tear of the indirect tendon all the way proximally, and that could be as a minor avulsion of one of the tendons, or it can be intramuscularly as the tendon goes within the muscle. And in addition to the muscle tendinous junction lesion, there's also a tendon disruption. And this can be some of the things that may affect your expectations and your prognosis for your return to play for your players. Then we have the iliopsoas. It's of course not only the psoas muscle, but it's also the iliacus muscle. The iliacus muscle kind of have two main muscle bulks, and goes down. It actually usually does not go down into the iliopsoas tendon, but actually has different separate tendons. And with the separate tendons, of course, also different muscle tendinous junctions that we will see the injuries also occurring in. And I've made an overview here. You can see from an MRI that we have the psoas tendon or the psoas muscle going down, the lesion here, as well as the iliacus muscle from the back. So two separate lesions, but more often there is an injury in the iliacus muscle actually. So from the posterior muscle bulk down in the tendon here, and they will usually be around that level of the muscle tendinous junction. So just to summarize the findings on the diagnosis and the imaging, we always have to focus more on the adductor injuries. 2/3 of those, 2/3 of all acute groin injuries will be in the adductors, and mainly the adductor longus. We have this discrepancy between the clinical examination and the imaging, where we know that the MRI scoring has high reproducibility, so we shouldn't be too concerned with that. Only the fact that there are a lot of imaging negative cases. We can generally trust in our adductor test, and the discrepancy is not because it's sports medicine physicians doing it. It's because our clinical examination tests are not that accurate for the hip flexor muscles injuries. We have to remember that if you're in doubt, if you have a negative finding on palpation, you're very unlikely to have an injury, so you can use that also to rule out other injuries, muscle injuries in the region. And we have a lot of different MRI characteristics that might be relevant for your prognosis. So I have to touch a bit on the treatment as well of acute groin injuries, and there's unfortunately not a lot out there in the literature. We're starting to look at it a little bit more with the injuries that we have, who've all gone through a standardized program. But if we first look at the general expectations, we can look at the big WAFA studies, and we can see that actually the majority of acute groin injuries that you see in the clubs will be less than 7 days. As about half of them will already be playing within 7 days. So a lot of minor injuries. And what we see as clinicians, or what I usually see, is the ones that are a little bit larger when they decide to come into the hospital as well. And we have just a small number that becomes very severe. So in general, it's not a huge problem. What is the bigger problem is the high number of re-injuries. So if we look in the same study, they had about 18% re-injuries in the adductor, and down in Qatar, we looked at, Andrea mostly looked at the epidemiology of the Qatar Stars League, which is the best football league in Qatar. She saw that 27% of the players who had an acute groin injury had reoccurrence, so a very high number, and probably something that we need to focus a lot of our attention on. If we then just look overall at the management of groin pain and want to find out a little bit more on acute groin injuries, we of course go to our systematic reviews to help us, and there's a lot of those. We did 72 studies. Out of these 72 studies, only one study was on acute groin pain, and that was a study on adductor lung avulsions from the National Football League. And only 14 cases in a retrospective study. So that's kind of the biggest one on non-operative management out there. And they're not able to provide us with a general rehabilitation program that we can follow because they all were from different clubs and had different treatments. But what we can see in this group of players is that these, even though they have a big injury, and a big avulsion injury, they were actually fairly fast back to return to play, with a mean of only 6 weeks and ranging from 3 to 12 weeks. And all of the players that had an injury actually went back to play at the same level. Performance level is not set, but at least back to the NFL. If we then look at a subsequent study, also a very small study, only 6 cases. Here they also gave an injection, but other than that, mainly based on an exercise program. And we can see also in this case we had 100% return to sport. They claim to have no re-injuries at a mean follow-up of 18 months, and they're around 3 months to get back to play in general. They waited a little bit too long with the strengthening exercises, in my opinion, but that's another point. So we see a lot of these adductor longus avulsions. I've probably seen around 30 from now, but we've been able to include 17 of these in our study, and I just look quickly at our numbers so far. So this is something that's flowing, and we don't have the full data here, and it may change a little bit. But this is the actual overview of the patients that we've seen, different numbers for different time points. And what we can see is that the first time point we had is to be clinically pain-free. And that means that all your pain provocation tests are negative. They've been able to do all the phases of their treatment program indoor, and also with some change of direction and run-in drills. And we can see the median return to play of that is just below 2 months. We have a general thing around 2 months, but we can see that there are some that are really fast as well, and some that are a lot slower. Then we get out on the pitch. If it's a football player, most of these are football players. They do sport-specific training with a lot of change of direction and progressive kicking. And the clearance for that was around a little bit more than 2 months again, as you can see here. And when they then got discharged, went back to the club, had some partial trainings, and actually had their first full training, that was around 3 months for most of them. So how do these guys look when they leave the hospital? This is the ones that completed all our rehab program, and we used the hip and groin outcome score to measure their perception of their pain and function. And we can see in general they're feeling really, really good, and this will also indicate that they're ready to go back to sport. If we then just do a clinical examination on them, we can look at different elements. What I'm presenting here is just some asymmetries. So we have our abduction range of motion in a side-lying test. In general, that's very similar. Same for the bent knee fallout for side-to-side difference. We have our eccentric adduction test, side-lying version, and a supine version where we get out and out of range, and we have a ratio here. So you can see that it's just around 1, a little bit below, but when we get out of range, almost 20% difference with the injured leg being a little bit weaker still. But even here in the median around 2-3 months, they're almost back to the normal strength and in full function. We then looked at them and had them come back after 1 year, and we did another clinical examination. We also did an MRI, and we gave them the questionnaire again. We had one re-injury, so one player who came back and felt some pain during a kick, and he had to take a little bit time off. It was around 1 month. There's some psychological things in over that. Then we had another player who had a little bit of continuous pain when he was doing goal kicks, but that was in the beginning, in the first 2 months, because when we look at the 1 year follow-up, they're again really, really high. So the main point of this, we want to look at the strength and the range of motion again. Have they recovered? If we look at the range of motion, it's generally the same with our interquartile ranges here, so that'll be 50% of the population. Still, as a median, they're still a little bit lower in strength, but less than 10% in general. And this will be influenced by a lot of stuff which is out of our control, of course, with the clubs. So if we look at the treatment, I've only focused on the adductor longus avulsions because I know Ernest is going to talk about that and with a lot larger numbers. But in general, the evidence is poor for acute groin injuries, and we'll change that for next year's Congress. But 90% of the adductor injuries in elite football return within a month, but we have these high re-injury rates. So just on the adductor longus avulsions, the main point of presenting this is that if you get the players in, you start early, most of them can do well. So they can be managed successfully with an exercise-based treatment. And what I usually say is that they'll have a return to sport within 2 to 3 months and be back at full training and capacity. It very much depends on the compliance, in my opinion. And the good ones that really put in an effort will be closer to 2 months. You will have some which are clinically pain-free before that and can do a lot of stuff, and then you have to consider what are the risks of sending them back, even though it's only been a month, for instance, with one of the guys here. And when we look at them after the 1 year, they're actually doing really well. Yeah, so that was it for me for this show. I want to thank everybody at the Congress. I love coming here every year. And if you want to talk more about groin pain, you can always send me an email or come down and visit in Qatar. Thank you.
Hello? Yeah. So where is the...
This is the laser.
Yeah, okay. Good morning. It's an honor for me to speak at the Scandinavian Sports Medicine Conference. I have the pleasure to talk about adductor avulsions. It's a bit in the sports medicine the sports medicine community has treated these injuries it's a bit like casual sex. They're all happy to have the fun, but nobody has actually done an effort to get to know this injury a bit better, let alone to meet the parents. So they even got the name wrong, because actually adductor avulsions are very rare injuries, so pure adductor avulsions. So plaque injuries is probably a better term, but I know those things take time, so I'm not going to confuse you too much. So we have currently about 180 athletes with adductor avulsions plaque injuries. About 110 are football. We have 82 professional football players, and of those, 24% are internationals. About 12% of our athletes are rugby injuries, and then the rest is martial arts, skiing, water ski, ice hockey, and other types of sports. So when we have to decide on surgical treatment, we need to consider a number of factors. We need to think about the extent of the injury. We need to think about the level of activity. Is this a professional athlete, recreational athlete, or non-athlete? We need to look at the type of sports activities, because you have different demands for different sports. So if you're playing rugby, then it's less likely that you're going to do kicking. If you play football, then obviously kicking is very important. So therefore, you need to look at your adductor strength on initial presentation. You need to think about why conservative management fails, and you have to analyze this. And we have to think about bone health as well, which is very important. And obviously, you need to involve your patient in the decision which way you want to go. So if we look at the extent of the injury, I think it's important to go back to the anatomy a little bit. And so an important structure is the anterior pubic ligament. And the anterior pubic ligament crosses over the pubic ridge and crosses over the symphysial joint. And laterally, the anterior pubic ligament continues into the inguinal ligament. And this is important because you can see that your pectinase here inserts onto the ramus, onto the ramus and your pubic ligament, your inguinal ligament. And then distally, your adductor longus anchors onto the anterior pubic ligament. So the tendon anchors onto the anterior pubic ligament. And from the top, the pyramidalis muscle arises from the anterior pubic ligament. So in a schematic drawing, we see that the central stabilizing function of the anterior pubic ligament, and then pyramidalis muscle and adductor longus. And if we look on the sagittal, we see the adductor longus tendon, which continues into the anterior pubic ligament, and then into the pyramidalis muscle, which is the only muscle anterior to the pubis. And you can see how the fiber cartilage of the adductor longus is actually wedged in between the adductor tendon and the pubic bone. So what happens when we have an avulsion? So we have very often a co-contraction of the pyramidalis muscle and the adductor longus. And what it does is it actually lifts off the whole plaque complex from the anterior pubis. And this is what's happening. So you see that the fiber cartilage gets stripped off, and so does the anterior pubic ligament and pyramidalis. And when more displacement occurs, then the medial part of the anterior pubic ligament, medial to the plaque, can also become disrupted. And when it becomes disrupted, the whole complex can displace laterally. And with further displacement, when the longus moves even more down, the adductor longus can become separated from the pyramidalis muscle. So if we look at our imaging results, we see that in those plaque injuries, in 90% of the cases, the plaque is actually stripped off from the anterior pubis, so there's disruption of the anterior pubic ligament. In half of the cases, the pyramidalis is displaced, and of those who are displaced, about half of them, the pyramidalis is separated from the adductor longus. when the plaque remains in situ, and when the anterior pubic ligament stays intact, that's only accounting for 10% of the case. And these are the really true adductor longus avulsions, because for all the rest, other parts of the plaque are involved. And the more significant injuries, then you can see that the pectinase can be partially avulsed as well. So it's actually like you're pulling on a curtain and it comes down partially. And it's important that we also look at the different types of sports with regards to this, because obviously if you look only at football, you see that there's only 20% partial pectinase avulsions. But in rugby, this already goes up to 40%. And in sports like martial arts and water ski, there's 100% incidence of partial pectinase avulsions. So in these type of sports, the injury is a lot more significant than what we see in football. Where you play is important. So in professional football, being a striker gives you the highest chance to have an avulsion of your adductor longus and your plaque. And the safest place is to be in the midfield. So 24% of the professionals that we see were international, so perhaps the number of games and fatigue can be a role in having those injuries. And about 40% had pre-existing adductor symptoms, one way or another. 1 in 3 had steroid injections prior to the surgery. If we analyze failed conservative management, well, we define failed conservative management as basically symptoms over 5 weeks after the injury, and with a range to about 40 weeks. We see that in this particular group, about 40% had associated partial pectinase ruptures. In 80%, there was the plaque was stripped off from the anterior pubis, and in 56%, the pyramidalis was still attached to the adductor longus. Now, why is this important? Well, you have two active muscles that are still working, and they're pulling they're pulling on each other, so they're actually stopping the injury from scarring down. So this is, in my opinion, especially in professional sports people, something that I would fix immediately all the time. So we need to look at bone health as well, because bones like to be covered by muscles. And it's important because there's more interaction between tendon and bone than just a mechanical one. There's also biochemistry communication between tendon and bone. And we see that in some of the chronic avulsions that we see. So we developed a method to measure bone density in the symphysial area. And we see that in some of those spaces there is quite a significant drop in bone density. So normal values are about 1 and 1 or higher. And we see that they can go really very low. So we need to address bone health issues as well. So I think we can agree that at the moment there's still not a consensus on treatment. You can see from the anatomy that comparing it with adductor anatomies is a gross oversimplification of things. So we need to have a much more anatomical approach. And if you look at these kind of injuries, the history is very important. And so the overall majority will tell you that they felt a pop. So that already points you in the right direction. But also look at the geography of your ecchymosis. So you can see it's not crossing the midline, it's on one side, it's in the lower abdominal area, it's over the adductor area. So now we have involvement here of both the adductor longus and the pyramidalis muscle. Imaging is very important because the right imaging will help you to really look at all the components of your plaque very well. So you need to do sagittal images, and you want to look for this typical appearance of the fiber cartilage, which looks a bit like a shark fin, and also the axial oblique pictures. And typical on the axial oblique pictures is that you want to create that picture of a butterfly. And a butterfly is formed, the wings of the butterfly are the bone and the fiber cartilage of the adductor longus. And when the wing of the butterfly is broken, then we know that we have an adductor avulsion injury or plaque injury. So let me run through the different types. So first of all, the partial avulsion of the fiber cartilage. As I explained, this to me is the only real isolated adductor avulsion. And basically what's happening is that in this case, only the blue has become separated from the pubic bone, but the attachment of the anterior pubic ligament remains completely intact. And this is the MRI image. So the red area, with the red arrow, you can see the intact anterior pubic ligament. You see the increased signal under the fiber cartilage, indicating a partial avulsion. And here on the sagittals, you see that at the tip of your pubis, your anterior pubic ligament is still intact. Pyramidalis has no edema, so it doesn't look injured. And you can see there is only this partial avulsion. And typically is that a lot of those injuries, when they come to clinic, they've never been diagnosed prior to coming to clinic, often because they haven't done the right imaging. And following a partial release for those patients who obviously have gone through some conservative management, because the majority are professional football players, we get them back playing in around 6 weeks. And then the rehab program is a standard adductor rehab program. And the next type is the complete avulsion with minimal displacement. So the plaque is stripped off from the anterior pubis. So this is what's happening. So the fiber cartilage is stripped off, and so is the anterior pubic ligament. And as I explained, if the medial aspect of if the anterior pubic ligament medial to the plaque is disrupted, then the whole complex can move laterally. And this is a player from the Bundesliga who lost the whole season with his injury. And what you can typically see is that, so you can see here your pyramidalis muscle. It's very easy because it's the only muscle in front of the pubis, so you don't even have to think about it. And so you can see that at the tip there's disruption of that anterior pubic ligament, which is sitting about here. But if we look on the axial oblique views, we see our butterfly here. You see this is empty. And the fiber cartilage here has been displaced laterally. So we know that anterior pubic ligament medially is disrupted. So, but obviously, if the fiber cartilage is avulsed, it can avulse in different ways. So it can leave a small remnant, and in that case, the bridge over the pubis remains intact, or it can avulse completely. So all the fiber cartilage is gone off from the anterior pubis, and then you can see that your anterior pubic ligament is floating. So the bridge, in that case, over the pubic symphysis is disrupted. When we look at things surgically, we see, you open the tendon and it looks completely normal. And when I initially started to do those injuries, then I've been fooled on quite numerous occasions initially, because you get a scan that tells you that you've got a complete disruption, and then you look at things, and then it looks normal. So here's the adductor longus. You see the tendon fibers of the adductor longus, and when we follow it a little bit higher, you can see the anterior pubic ligament, which is very easy to recognize during surgery. But if we then look under the fiber cartilage, we see that there is a fibrotic area where the footprint is of the adductor longus. And basically, treatment consists of putting in some suture anchors, suturing the fiber cartilage back into place, and then repairing the anterior pubic ligament and pyramidalis back to the adductor longus. The next type is the complete avulsion with significant displacement. So obviously here, again, everything is stripped off, but complex is moved more distally, as you can see on this drawing here. And this is very interesting. So you can see that this little asterisk, which shows you the pyramidalis muscle. You can see the anterior pubic ligament here. You can see the shark fin, which is out of place. Here, well, if you look at the cross-section of pubic bone, it doesn't look the normal shape that you see when you're a bit medially, so you know that the whole complex is positioned laterally. But then what's important as well is this. If you look at this muscle, it's quite a thick muscle. And we see that when we started measuring the thickness of the pyramidalis muscle, we saw that when that muscle was about 7-8 millimeters to 9 millimeters wide, that it was more likely to stay connected. So therefore, the thickness of your pyramidalis determines a little bit what algorithm that you're going to follow. And if you look at this was a player with a bilateral avulsion. Now we're right on the midline, and in here you can see your internal tendon of your rectus abdominis that goes up all the way here. And when we look on the sagittal here, you see your pyramidalis muscle. It's full of blood here, and you can see the blood separates the rectus abdominis from the pyramidalis muscle. So when further displacement occurs, and you get to the stage that your pyramidalis becomes separated from the adductor longus, and this is what we see. So you can see the fabric cartilage of the adductor longus. You see the muscle here, and here we see there is no fabric cartilage, so you can see the footprint of your fabric cartilage, and you can see here the anterior pubic ligament. And it's interesting because you can see that whole structure is lifted off from the bone. And and that explains that whole plaque has been lifted off. And you can see the anterior pubic ligament here, and you can see the muscle belly of the pyramidalis quite nicely as well. So the most significant injuries, as I said earlier, are those where also there is a partial pectinase avulsion, and this is what we see. So you can see your adductor longus, you see the pectinase, and you can see how the tear, the separation always occurs through the anterior pubic ligament, and here you see that has torn through the anterior pubic ligament, and then it continues with a longitudinal split of your inguinal ligament. And the way, of course, you treat it is with some suture anchors that you put into place. And I wanna mention this specific case because Andreas knows it. When he came to see me, he walked in the right moment. So this was somebody from the special forces, and 8 months down into his rehab, he still had quite a poor function of his adduction, and this is his clinical picture. So if you look at on his MRI scan, you can see if you look at the shape of your pubis, you know where you are. And so if it's a bit more round like this, then you know you're a lot more laterally. And what you can see is that you can see the inguinal ligament here, and if you follow the inguinal ligament down, you come to the fabric cartilage of the adductor longus. And this is how it looks during surgery. So you can see that inguinal ligament here, coming down to the adductor longus, and see how far it has been displaced. So, and obviously every time that patient adducts, he pulls on his inguinal ligament and it causes pain. So I think these kind of injuries, it's very important to deal with them acutely, because if you have to deal with them 8 months down the line, your dissection becomes quite difficult, and you spend an awful lot of time freeing everything up and trying to mobilizing back into place. But still, you can get good results with it, and you can mobilize things back into a normal place in most of the time. So we use a post-operative rehab program. It's a bit of a consensus that we did with the medical and physio departments from the Premiership and Championship teams, just to get a bit of an idea in the stages and when we start to do what. The first 3 weeks I tend to do not a great deal, and so I let them mobilize. We start with strengthening work from after the 3rd week, and then you can actually you can fast forward a little bit. Usually, when we're about 6 weeks, we do some strength testing, and that gives us a bit of an idea how far they are from return to full training. But we do have to think about bone health as well. We give all the players vitamin D supplements. Vitamin D receptors are everywhere. They're in your bone, they're in your skeletal muscles, they're in your intestine, facilitating active calcium transport. So it's a very important molecule. We also do electrostimulation. And why do we do electrostimulation? Because a muscle at rest produces myokines. And one of the myokines that it produces are the myostatins. And myostatins cause sarcopenia. So in this initial stage, you want to avoid too much muscle atrophy. In those patients who have lower bone density and symptomatic symphysial osteopenia, we give them also substitution. We give them bisphosphonates, either oral or with infusions. So in professional football, about 63% get reattachments, 22% get partial release, and about 15% get conservative management. But I have to say that those figures change all the time. Every time I have to give this talk, I look through my database and things keep changing. So the selective partial release gives us, on average, a return to full training after 6 to 6.4 weeks, and a return to playing after 8 weeks. The reattachment of the plaque gives us a consistent return to play at 13 weeks. But it's coming down because we have been starting to put more and more focus on the supplements, trying to understand the tendon and bone interaction to help there as well. And I think supplements and electrostimulation can really help to move forward your rehab. I've been very lucky to deal with a lot of high-level athletes, and they have been appreciating what you're doing. If you see that Steven Gerrard even puts me higher in the list of his index and pulse scores, that's great appreciation. So, take-home message is you have to think anatomy. And Per and myself, we've been crusading. We've been crusading to get this into the sports medicine community. But I think we're winning. We're winning. But we will continue with our crusade until everybody believes what we say. Thanks.